scale, which we collect in foot and ankle, and its role in sort of anticipating or predicting outcomes in patients. And Dr. Van Wyck and Dr. Rollins had reached out to our department chair saying that they've essentially identified a very effective treatment program for patients who have sort of suboptimal coping skills, pain catastrophizing, and potentially lower resilience. It's called Empowered Relief, and they're going to talk to us about that and how we might collaborate as a group. We have an ongoing, we're developing a study with them to look at a specific population in foot and ankle alongside, hip and knee arthritis, sports, and spine. And so I've invited them to present to us today on their program and hopefully generate some good Q&A. So Jill and Modesta, thank you for being here.
Thanks so much, Dr. Hunt. We are thrilled to be here and to talk about Empowered Relief with you all. Like I said, I'm Dr. Jill Van Wyck. I'm a family doc. I work in Boulder, and Dr. Vanessa Rollins is a psychologist. We work together, and we're very interested in how we can help patients with chronic pain, but also in how we can hopefully improve perioperative outcomes and avoid persistent post-surgical pain. So we want to walk you through briefly the intervention that we're studying and interested in working on with you all. So the course is entitled Empowered Relief. It was developed at Stanford University, funded by multiple NIH institutes, delivered throughout the US and internationally. An efficacy trial was published in JAMA Open Network. And what they did is basically, we know that CBT, or cognitive behavioral therapy for pain, is effective at changing outcomes in chronic pain and also in acute pain, but it's quite cumbersome. It's 8 sessions delivered over 16 weeks and quite cumbersome. So what they did in Empowered Relief was really distill the key portions of CBT into a single session, 2-hour course, which can be delivered virtually, and that it was found non-inferior to the 8 sessions of CBT, which is really kind of exciting for those of us who are interested in behavioral interventions for pain. Makes it much more approachable. So they studied it on pain intensity, pain interference, catastrophizing, self-efficacy, and bothersomeness, as well as some other things, and it was found non-inferior. That study is available if you're interested on JAMA Open Network. And we're really interested in avoiding the development of chronic pain or persistent pain. They also show, some of their studies do show a decrease in opioid use, which is of course really important to all of us. And we're just also interested in how do we get patients back to their normal activity? How do they suffer less, live better, do more of what's meaningful to them? So when you look at the evidence around pain, we oftentimes will treat it just as a biomedical problem or an isolated symptom. But really what I think the more interesting data shows is that pain really is an interaction between psychological and biological factors, as well as sociological factors. So really most effectively treated in a biopsychosocial or whole person approach. When you look at the definition of pain, it's a noxious sensory and emotional experience. And so to best treat it, we really want to have a focus on addressing that full definition of pain, providing whole person pain care and making it rapidly accessible to patients. So that's something that Dr. Rollins and I are really interested in coming up with creative ways to do. We know that if we don't address factors such as the impact on the trajectory of their pain, their mental, emotional, and behavioral responses, that we're really doomed to over-medicalize many patients while they continue to have poor outcomes. And I'm sure you've seen this in some of your patients with the same intervention. Some do really well and some do really quite poorly. So we're really interested in seeing if there's a way that we can intervene in a relatively brief and effective way to make a difference there. So when you look at pain-specific psychological factors, they're highly predictive of outcomes for patients who have chronic pain and also for patients with acute pain and in healthy individuals. So pain catastrophizing is a term that we use fairly often, and it's the tendency to magnify the threat value of pain and to have a certain level of helplessness in the context of pain. It's really quite important in the development of postoperative pain, lower physical functioning, and decreased quality of life indicators after surgery. And I think that when we look at resilience as an outcome measure, that really maps really well along with the patients who have pain catastrophizing. When you look at the data, it also is really strongly mapped to the persistent opioid use at patients at 10 years of follow-up. So I know that oftentimes we look at shorter outcomes, but we're also really interested in those long-term chronic outcomes and what can we do to help prevent those. It's really interesting when you look at the data, you actually do see in patients with high pain catastrophizing or low resilience that you see changes in MRI on the shape and the functioning of neural patterns and the shape of the brain at rest. So it's really interesting that you can see when you intervene and help patients with high pain catastrophizing develop coping skills, that you can see changes in the shape of the brain and sort of the ability of the way that patients will be primed for higher levels of pain and lower levels of function. So we also have some early data on surgery, and I'll turn it over to Dr. Rollins to talk a little bit more about that.
Thank you. So yes, this is true, what Jill talked about with regard to pain catastrophizing, with regard to how it changes the brain and outcomes. This is true in surgery as well. So in fact, pain catastrophizing and other pain-specific factors are treatable. So we know that CBT increases prefrontal gray matter in patients with chronic pain. And one study found that just 11 weeks of CBT altered the structure and function of the brain in concert with reducing pain. And those improvements were mediated through that variable of pain catastrophizing. So Jill talked about what pain CBT is. The thing about that is it tends to be, very labor intensive. It's 2 hours over 16 weeks, and not everybody is willing or interested and able to participate in that. One meta-analysis found that pain catastrophizing best predicts post-surgical chronic pain and best predicted long-term opioid use after surgery. So the barriers to CBT are formidable, right, for that 8 weeks. So it's around insurance, and most insurances cover that now, but it's really the copays that tend to be cumbersome for people. It's the amount of time that it takes. It's a desire to or an interest in participating in a psychological therapy that not everybody's interested in. It's things like travel. It's all the same stuff that people have around going to physical therapy, that it might work, but it really is formidable. And finding psychologists who are versed in chronic pain is also really a challenge. There's just not a ton of them out there who have availability. So our solution is empowered relief. We've looked at a lot of different things, but we took the training and we were really impressed. So it's a single session pain class that rapidly equips people with actionable pain management skills. So we can deliver it in a virtual format or in person. We can see up to 20 people or more in a visit, and anyone can attend. It's not psychotherapy, and I'll talk more about the key components, but it's not psychotherapy, so family members can attend. The other important thing about it is that there's no barriers to who can exactly attend in a virtual format. So sometimes we see people that we wouldn't normally see in a group, who wouldn't be appropriate for a group, that we can see in a virtual group. So what Empowered Relief does, it takes that brain on fire and turns it back into just a regular old campfire and really strengthens the areas of your brain that are associated with pain processing. So as Jill mentioned, it condenses all the heavy hitting parts of CBT, all the parts of CBT that we know work, the psychoeducation, relaxation, thought reframing, and behavior change, and condenses that all into a 2-hour class. And they learn in that short amount of time various ways to dampen pain processing in their nervous system with easy to use skills. And then as we're going through, they're completing a personalized plan for empowered relief. And at the end, they receive a relaxation audio file that they integrate into their daily practice as part of their plan. And it really shifts them from being sort of passive recipients of medical care to having an active role in their own pain care. So the United States HHS Interagency on Pain Management Task Force cited empowered relief as a promising and scalable behavioral treatment in 2019. So highlight scalable, accessible, low cost. It's open to all patients. Family can attend. You can treat people in volume. It is evidence-based, and the benefits are lasting. So as Jill mentioned, in that 2 hours, it was comparable to CBT, which we know over decades of research that CBT does work around pain intensity, pain interference, pain self-efficacy, the bothersomeness of pain, pain-related behaviors, improved sleep, improved depression, improved anxiety, improved fatigue, and most importantly, these improvements were sustained at 3 months. So there's some ongoing research around empowered relief and surgical outcomes, but so far, and there's more ongoing currently, but so far they studied it in women getting breast surgery and found that those women stopped their opioid pain medication about a week sooner after surgery. And then in orthopedic trauma surgery patients, they found that it reduced pain after surgery and up to 3 months later. So findings are promising that this intervention could be useful around pain relief and recovering from surgery and injury. So these are all the folks that are currently participating in empowered relief. There's some long-term studies around surgery and use in primary care in Canada. So as Dr. Hunt mentioned, we are very interested in partnering with orthopedics around providing this as an opportunity to improve post-surgical outcomes, particularly in at-risk patients. Dr. Hunt mentioned the people who have low resilience, which is also associated with pain catastrophizing. So we think it's scalable, it's accessible, it's good acceptability and engagement by patients. It's a class, not a psychotherapy. It's efficient, it's economical, it's a low burden to patients and the organization, and it really helps de-emphasize the focus on medications. So that's it for us. Any questions?
Thank you both for that. Questions? Mark, please.
Yeah, so Vanessa, I'm fascinated by this because so much of this would imply that we should be anticipating these pain responses and behavioral responses preoperatively. And we should have a far more efficient way of evaluating patients preoperatively in anticipation of these behaviors. What is your recommendation, and is it time and cost efficient to do preoperative evaluations on all of our patients?
That's a really good question. And Dr. Hunt, I think you have a really good answer to that, because that's sort of what you're doing, is coming up with some ways to predict which patients are going to have terrible outcomes. And one of those variables would be around resilience and also around pain catastrophizing.
Yeah, so I think the challenge, Mark, you're spot on. The challenge is in the metric and the threshold. So as Vanessa mentioned, the work we've done has demonstrated very clearly that patients with lower resilience pre-op start at a worse place and end at a worse place than patients with higher resilience. Probably more importantly, the higher resilience patients have a bigger delta, a bigger improvement. So all patients improve, but the higher resilience patients get to a better place and improve more than their preoperative values. But the intervention is what's challenging, right? So we've observed that in our retrospective data, but how do you trigger a treatment like empowered relief? And what's the best metric? Is it BRS? Is it the pain catastrophizing scale? So we've looked at that, and Vanessa and Jill, you know better than me, but it's not a short survey, and it's got some scary questions in it. And for our patients that don't deal with these things, filling out those surveys can be a little bit unnerving, when there's questions about, suicidal thoughts and whatnot. So that's where we want to get as a group is, make sure that we're administering an effective metric where we know what to expect. And we set thresholds that would trigger those patients to get an intervention like empowered relief, and then obviously measure the effect by looking at their longer term outcomes. Does that answer it?
But to Mark's point, if I may say, I think this is fabulous, and that why not offer it as an opportunity preoperative to all patients? There are programs in spinal surgery and hip surgery and so forth that you go to classes before you even have the surgery to learn coping skills, home care skills, and so forth and so on.
Yeah, and I
And
think
that,
sorry.
Go ahead.
Well, I was going to say, I think that's reasonable in the right patient. I guess my point is we got to figure out who the right patient is. Like I'm probably not going to recommend this for, a patient who's having like, a ganglion cyst removed or an ankle scope for impingement, because we don't see pain as a long-term issue in that population. But for like the bad deformity, the advanced arthritis, the third revision operation, or the patient that has demonstrated on their surveys to have lower resilience or higher pain catastrophizing, like absolutely. But I don't think it's efficient or helpful to recommend this to every patient that comes through the door or is advised to surgery. But for the right patient, absolutely, having this as part of the protocol makes a lot of sense. But I want to measure it so we can ultimately identify the right patient, so that we're not, we don't want our patients to feel like they're guinea pigs. We don't want our patients to feel like we're recommending something that's not going to be useful. So I want to maximize the utility.
Yeah, that's an interesting point, in that there was a study at the Cleveland Clinic where they now have integrated this into all patients who are undergoing spinal surgery, that it's a requirement as part of, not a requirement, but it's highly recommended. I think they said they had about a 60-70% uptake of people who were referred to take the class prior to spinal surgery. And we did have those thoughts about people who are getting joint replacement. You take so many of those classes about your recovery and about what that's going to look like. This would be an easy thing to add in as something that we know would be helpful in people's recovery.
So Vanessa, I've got a very interesting observation here. I do a tremendous amount of international work and surgery, and in many, many countries. And one of the most remarkable observations is the lack of pain, and I mean lack of pain, in many of these patients. These are generally impoverished, underserved communities in the world. And the lack of pain, absence of pain, and the lack of need for opiate medication postoperatively, both in children and adults. Mm-hmm. Can you comment on that, please?
Well, that could be for a variety of different reasons, but I think that data is consistent in some other areas too, like PTSD, for example. I think it could be around support network. It could be around expectations around surgery, right? That in the US, we have high expectations of not being in pain, of not suffering, and that we don't have the internal mechanisms necessarily to be able to deal with suffering. There's this expectation that I can't be in any pain, that would be wrong if I felt anything terrible or awful or horrible. Whereas in other countries, that may not be true, that there's some expectation that I'm getting surgery. So, I might be in some pain. I'm just so grateful that I'm having whatever fixed that I don't have the time to get bogged down in my own suffering.
So Vanessa and Jill, what are the right triggers, do you think, or what are the most effective triggers? Like you mentioned spinal surgery, and I would agree that anyone undergoing like a spinal surgery would be at risk for having an outcome altered by pain catastrophizing or resilience. But I mean, or joint arthroplasty is another one, because arthritis is so debilitating. And I think in our world, in addition to ankle replacements, deformity correction, because those are usually big operations that require fusing joints, breaking bones, prolonged non-weight bearing, higher levels of pain and need for pain medications. So is that the right way to do it, is to look at the procedure rather than the patient? Because it strikes me that like where we're going to make the biggest dent is going to be the combination of procedure and patient by some preoperative metric.
Yeah, I think those are the questions we want to answer, and we don't know yet, but my strong suspicion is patients who will have a prolonged period of change in activity are going to be at risk, and that patients who come in with just a sense that this is overwhelming and awful and a lot of anxiety around it are going to be at risk. So those would be kind of the two areas, the intersection of those two areas I suspect are going to be where we'll find the useful data. Do you have additional thoughts, Vanessa?
Yeah, I agree with you. And I think we've been delivering this to patients who are about to have mastectomy, and it's useful, but it's a little off. And I think that the missing piece is the association with chronic pain. So I think the patients who maybe have had pain for months, years prior to their procedure, I think this is going to have the greatest impact. The original research was around chronic pain, and I think it's really useful for preventing persistent post-surgical pain, but I think it's going to have the greatest impact on those who've already had that unhelpful pain mindset. And those are the folks that have had chronic pain for a little while.
Hi, this is Courtney Grimsrud. That was going to be my question. I feel like I see a lot of patients who already have chronic pain or diagnoses like fibromyalgia and that sort of thing. And it seems that those patients do worse always. And so was if they can benefit from this. And then also my question on top of that is, can you do this post-operatively at all, or is it a pre-operative kind of intervention?
Great question. Thank you for asking. So it was originally designed in chronic pain. I agree with Vanessa. That seems to be where people really have some understanding. It has been studied preoperatively. It hasn't been studied specifically postoperatively, but we do this with patients with chronic pain. So I think it's very appropriate in that setting too. So we're happy to take patients who have chronic pain. Absolutely. We're happy to work with patients after surgery if it's helpful. And I think it can be really useful particularly in patients who do have sort of a helpless feeling or a unhelpful pain mindset is the term we use. So just kind of a sense that they don't have a lot of empowerment around their own pain.
So I think what we're going to do is, so we're putting together a study in collaboration with some of our other partners to identify some of the high-risk patients in our practices and provide this intervention, provide this program as a recommendation as part of a study. And we're sort of piloting it to look at the impact. And obviously we have a large historical control group to compare it to. Because I think the biggest impact is going to be patients that Courtney mentioned, those with fibromyalgia, chronic pain, chronic use of opiates, poor resilience scores, like that's where I want to see the trigger. I don't think that we're going to measurably move the needle in a high resilience patient that isn't really at risk. So I think if we identify those patients and really identify that it works, then I think we can create the right algorithm, the right triggers. And that's a heavy lift, right? And we have 7 orthopedic surgeons, 3 podiatrists. We have a big group, but that's kind of where I see this going. But Vanessa and Jill, could you provide? Do you have, like, I know you had a link in there in your PowerPoint. I'd love to invite our group here to get that overview video so that they can view it on their own time and get a better idea of kind of what this intervention looks like and start to think about it in their own practices.
Sure. Do you want us just to send a link to Jana? Is that?
Yep. Yeah. If you send it to Jan, she'll be able to disseminate it. And then to the extent you have like the list of publications or whatever you're willing to share, this PowerPoint, we'd love to have that as a resource to look at as we're moving forward.
Absolutely.
Sure, yeah.
Do that.
You know, in relation, Jay here, sorry, I have a little cold. In relation to Dr. Meyerson's comment about the kind of societal and cultural differences in pain, I had picked up a Life magazine from the late 1950s where Ernest Hemingway had written a number of articles about bullfighting. And in one of them, he was counseling a friend of his who had gotten gored by a bull. He was in the hospital, and he wanted to stay sharp and didn't want to take opioids. And Hemingway had made the comment that if he was in the US, they would have snowed him. Like he wouldn't have had a choice. He would have had to take pain medication.
Yeah.
So it's interesting how long that's been
Yeah.
sort of a societal thing in the US.
That's interesting.
Hi, this is Renee Kafka. I'm a podiatrist in the group here. I also happen to be someone who's had spinal surgery, so I've walked through some of these things myself and have done my own work with pain counseling for my own self. So I actually can relate really well to the training that you're doing. I have done it, not that particular training, but a yoga therapy training out of Canada called Pain Care U that has been really wonderful for me. And it's been a great connection point with my patients, as well as just being able to talk to patients about a lot of the things that you were talking about, like how that pain, that brain connection to pain, and how to shut off some of those like thoughts and how to, transition those thoughts. I have my own talking points that I use with patients. I have my own things that I refer patients to both online, YouTube, stuff like that I send patients, like things that I've used in my own toolkit dealing with my own injury. So I'd love to know how to incorporate this into the group, how to get patients to you. Is there anything beyond that one session? Like, hey, I came to you guys, I did this session, it's really helping me, but I need some sustaining tools. What do you guys have up your sleeves for that?
Well, thank you for sharing that. That's really useful. So you said that the program was called Pain Care U?
Pain Care U out of Canada with Neil Pearson. He's a yoga therapist specifically, but a lot of these talking points that you talk about, that's what they incorporate into their therapy. But yeah, so but your program sounds like a really wonderful like version of that. But I was wondering, people don't necessarily want to sign up for that 8-session 16-week thing, just like you were talking about, that this would be much more effective. I don't necessarily know that everybody has time or even the energy or desire to be in those long-term programs, but how to can they just come back and do the program again? Like, how do you, if they just need a little touch point with you, like, hey, I was doing great, but now I'm kind of slid back a little bit and I need a refresh. Is it something they can do a second time? Do you guys have other resources for them?
Yeah, so patients have asked that repeatedly. Is there sort of a follow-up group that I could go to just to kind of keep me on my toes? So one of the things that Jill and I have talked about is kind of doing a follow-up visit with people. And 3 to 6 months is we're going to come back and outreach you in maybe a second follow-up group. That wasn't part of Empowered Release original research.
Right.
But just because that's been a desire of patients is I want to do this, but I'm afraid that my practice is going to fall by the wayside and I would like to have an outlet for checking back in again. So, I'm part of psychology training programs, so we have some help around that. So that is possible that we could do a second follow-up.
Awesome.
And then just to
great.
tag on to that is like Cleveland Clinic that was doing this for their spine surgery patients, they were allowing them to take the class a second time for free just to follow up. So we have batted that around as well.
I love it. I can't wait to utilize this. I feel like as someone who's had some pain, I feel like I have a lot of patients who come to me through word of mouth.
Yeah.
And they're very administratively expensive patients. So this would be a wonderful tool to add into the mix.
Yep. And what we love about it is it's palatable to patients in that it's a class, not a group. And we stress it's not a group, it's a class. And so for folks who normally would be like, that sounds kind of fishy, it's a little bit more palatable in that way.
And Vanessa, do you have like a playbook on how to schedule this? I mean, do you have resources that would sort of help us guide patients to it rather than just like giving them a website?
Yeah, we're fortunate to have a lot of support. So we will include in our email to Jana just how to put in a referral to us and a QR code. And if you want to put up flyers, you're welcome to. So we have a lot of support on scheduling, and we can take care of that for people.
Great. Well, that's terrific. Any other questions from the group? All right. Vanessa and Jill, thank you so much for being here. That was really insightful. And we look forward to collaborating with you and finding where this can fit in not only our practice, but the practice of foot and ankle and orthopedic surgery. So thank you for your time.
Yeah, thank you for having us. We're happy to be here.
All right. Have a great day, everybody.
You too.